Hello, good afternoon for everybody joining us. I really appreciate your time. My name is Eden Barnhouse. I am our marketing manager here at SlicedHealth, and I have the great pleasure of having a great conversation today with two of our founders and high-level executives. So I'm excited to introduce them here in just a second. Today, we'll be talking about the gaps between what you're paid versus what you're owed. This is a big question for a lot of people, especially about to hit that Q4 timeline, and there's a lot of questions that need to be answered before the end of the year. So we're hoping that we're able to answer several of those questions today. Joining me today, we have Liggin and Reese Walker. Reed is our CEO, and Reese is our Chief Product Officer. Together, they have been a part of the founding team of SlicedHealth. We are really lucky to have their time today, and I really appreciate their time. They're great resources for you. So as a level of housekeeping, I encourage you all to use the Q&A chat. Ask any questions that you would like to ask about the material to them, and we will have some time at the end for some Q&A. However, if there's anything we're not able to get to before the end of the session, I will make sure that our team follows up with you and your team directly. We also will have a recording available after the fact. This will not only be emailed to you, but also available on our website. So we'll make sure that you have access to that recording, as well as access to Reed or Reese, should you like to follow up with one of them and make sure that all your questions are answered. Before we get started today, we are going to cover topics about why hospitals are consistently underpaid and some of the systemic issues and complexities with that, what contract management looks like in today's day and age, and how tools like what we offer or what similar sponsor or vendors offer are helping teams like yours take control of what they are owed and bringing that back into their revenue stream. So as we get started today, Reed and Reese, if you'd like to briefly introduce yourselves, I'll turn it over to you. Reed, if you want to take it away first and just let us know where you're at and your role here in the company.
Sure. Thanks, Eden. I'm Reed Liggin. I'm the CEO and one of the co-founders of the company. I live in Woodstock, Georgia, outside of the Atlanta area. And basically, I'm a former pharmacist, worked in healthcare since the 90s, and basically mostly did clinical systems, worked with clinical systems, and I worked with McKesson for a long time and then got into being an entrepreneur. And we started SlicedHealth we formed it in 2019 and launched the company in 2020.
Thank you very much. Reese, your turn.
Hey, good afternoon. Reese Walker, I'm Chief Product Officer. My background is revenue cycle system support. Worked at a large health system. I'm currently in Macon, Georgia, which, if you're familiar, is almost dead center of the state. And yeah, I'm not doing this is not my area of expertise. So.
Well, we'll keep it short and sweet. I really appreciate...
Meaning webinars. I'm sorry.
I was like, you are an expert in what you do. I'll clarify that. I appreciate y'all's time today and thanks for joining us. As we get started, these are some of the areas of focus that we'll go into. If you have been a part of our webinars before, you probably have noticed this, but if not, we try and keep things very educational. We want to create as much of a conversation as possible between you all and our speakers. So we tend to do panel discussions. So as we walk through today, this will be a panel discussion. I will be making sure that we stay on time, but also any questions that you leave in the chat that are relevant to what we happen to be talking about, I will happily add in and we want to answer those questions live for you. Again, at the end, we'll have some Q&A time as well and make sure that those questions are answered there as well. But please feel free to participate and we'll go ahead and get started. So underpayments and denials are something that we talk about a lot. They are a hot topic in the industry. They are top of mind for everybody as they're talking about their revenue cycle and recouping funds and the reimbursement rates and things like that. So boiling down a huge topic, let's start with why are hospitals consistently underpaid? What are some of those root causes, and how might this have affected just some of the things the two of you were thinking about, or how Sliced Health got started? So, Reed, why don't we start with you? What did you see in the market that made this a relevant topic for you, or something that you wanted to tackle as you began to think about Sliced Health?
Yeah, thanks, Eden. Being someone who approached the market from the clinical side of the business, I'd worked in hospitals as a pharmacist. I worked at McKesson on the clinical side of the business for many years. And we had started a clinical EHR company and then evolved into the revenue cycle side of the business as we built that company out. And I was really surprised at what I saw as we ran that company. It was a previous company we had, and Reese worked with me there. Basically, I was really surprised that when hospitals submitted claims, one, how many denials there were, and then two, how many times payers didn't pay accurately, and that the claims were often being underpaid. And so that was a revelation to me, being someone who came from the clinical side of the world, and just how inefficient things were. The other side of the coin was that I had worked in a lot of large hospitals, or sold to a lot of large hospitals when I came from the clinical side. And that there were, as I came into the community hospital market, that bigger health systems had contract management and modeling systems to deal with the problem pretty much universally. And they were not without that technology. As I came into the community market, many, probably most community hospitals did not have this technology in place. And so I was really surprised at that. And then the other issue I saw was that the problem was growing. So from, you know, 2010, when we started that first company, to today, the problem has grown exponentially. We're topping more than 15% of claims are underpaid or denied at this point in time. And so it's just an ever growing problem. And I think at that time in 2010, when we first got out of, as I first got out of McKesson and we started that first company, the numbers were in the single digits. So it's grown tremendously since then. And so that was kind of the genesis of me being introduced to the problem and just watching it grow. And, there were a lot of issues and reasons why community hospitals didn't have contract management systems in place. One being just the cost of the systems that existed in the market. Two, the difficulty in installing and maintaining those systems. And then the work that it took on the hospital side to install and maintain those systems, just the heavy lift of the projects that were involved in installing those systems. And a lot of hospitals told us that they could not maintain the systems once they got them installed. So there were a lot of issues and just a lot of roadblocks to dealing with the problem, and it was an ever-growing problem. And when you ask people on the payer side, why is this happening? They would say, well, we're not doing it on purpose. We're just seeing claims that aren't coming to us properly. They're not coming to us right. But then, as you learn more about it, you see them using big time technology, very expensive technology, and artificial intelligence in a way that's almost weaponized to make sure that the playing field is tipped, is not level. It's the scales are balanced in their favor, and it's resulting in a lot of dollars that are not going to community hospitals. And so we saw that was the scales were really out of balance. And so that became part of our core mission at Sliced Health when we formed this company, to make sure that community hospitals were getting what was owed to them. So
Thank you. That was excellent. I always really like walking through that with you, and appreciate that. Reese, I'm going to turn it over to you now. You know, we talked a little bit about the unbalanced scales, and again, maybe not a system of doing it on purpose, but systemic inconsistencies. So, I wonder, could you speak to that for a few minutes and talk about some trends in payer reimbursements that you're seeing, or some of the inconsistent underpayment or the inconsistent payment trends or methodologies that you've been exposed to?
Yeah, absolutely. And like you said, they are using, big technology, and they do it across the board. So they process claims. They being the payers will process claims from a small 25-bed critical access hospital using the same technology that they process a 800-bed hospital. And so it's finding, all of the systematic issues, where the smaller hospitals don't have the same systems in place for the checks and balances to make sure that their claims are hitting every single little edit. And so they will systematically deny or underpay claims. And I don't think I never accuse a payer of doing it intentionally, but it seems like they definitely take advantage of some of those, some of those inconsistencies that we see. There's in several of our hospitals, coming from no contract management system to, either our system or any other system, they're coming off of very manual processes. They're using spreadsheets or PDFs. They may or may not have access to any of their contracts. And if they do have access to their contracts to see what they're getting underpaid, it might be 3 or 4 or 5 years old. There's been addendums. There've been new fee schedules that have come out. If you're a PPS hospital, even if you're critical access and you get a rate letter every year, do all of your Medicare Advantage payers load that in their system correctly? If I was paid a certain percent last year and that percent changes 2 percentage points, how long does it take my Medicare Advantage payers to get that updated in their system? And if it goes on for 3 or 4 months, are you catching that? Do you even know? So those are a lot of the ways that we see, our hospitals being underpaid, and it's just small changes that add up incrementally. A lot of it is also kind of, some of the EHRs have, they rely on auto posting and things like that. So when the remit comes in and the payer says, this is what we're paying you, this is the allowable, the HR just accepts that and moves on. There's no check there to say, well, we got paid 1,000. Should we have been paid 1,200, 1,500? What's the variance there? Is there a variance? And so, it might be easy to spot check some of those, but if you're not looking at 100% of them, you'll never catch that. So that's, those are some of the things that we're looking at.
I think, yeah, you made the perfect transition into how do you identify those underpayments, and you covered several of those things, but some of those complexities too that were covered in what you said. I don't know if you have much more to add about, we've seen just a lot of people have outdated contracts or some inconsistencies in how they look for underpayments. Is there anything you'd like to add to that conversation?
Yep. Yeah. So, I mean, absolutely. We see, like, just talking about Medicare Advantage, they have the highest volatility for denials and even underpayments. Again, mainly because those rates don't get updated on time. New fee schedules come out, they're not loaded. We've even seen some where, they were supposed to get $1,000 and somehow $100 was loaded. Well, that's a 90%, variance in what you were supposed to get paid. And I don't even know how that happens. I can't imagine that a payer sitting there manually keying data into their system, but we've seen it. And so, like I said, the Medicare Advantage authorizations are a that's a denial, but at the same time, a ton of paperwork, very vague terms. A lot of when we read hundreds of contracts, there's a lot of reasonable and customary language in there that is very vague. And so, constantly trying to deal with that. And then all of the different payment methodologies. You've got You got your OPPS, your PPS, your EAPG now, which is 3M/Solventum. You've got a lot of Medicaids that are using that type of payment methodology, and nobody in the hospital, I say nobody, most hospitals don't have the same technology to validate those payments are accurate or not. So they're just completely relying on the payers to assume that to pay them correctly. Again, a lot of manual processes still being done, spreadsheets, VLOOKUP, all kind of stuff that just makes it very complex to find these underpayments.
I was going to ask, what are you seeing commonly for how people are filing these contracts and how people are keeping track of some of this stuff? They may have the contracts in place and may have a system, but it still feels inconsistent. Are you seeing some trends with that as well?
Yeah, a lot of times the contracts may be in the CFO's drawer, and it's just, hey, here's our drawer full of contracts. The ones that do keep them electronically, there's very little way to search them, because most of these contracts required, I don't know about today, but I know 5-10 years ago, they required wet signatures. So you sign the contract, then you have to make a scanned copy of it. Well, that, until, a lot of OCR and things like that came out, there's no way to search that contract for different language. And when you're dealing with a 100-page contract and you're looking for one little specific clause in there, it's very difficult to find it, which is something that we're actually trying to help using some AI. More on that later, I think. But anyway, that's how we see that. And then, you signed a contract 4 years ago. Every year you have an addendum. The addendum or the appendix to that contract is only referencing one little payment. Maybe you added a clinic, or they changed the way they pay one piece of your contract. So now you've got to look at 5 documents as a whole and figure out, okay, well, this piece of this contract actually now overrode this piece of this contract. And so you've got, a lot of disparate pieces of paper or disparate documents that are all part of one contract. And so as that begins to happen, it becomes very difficult to even understand what you're supposed to be getting reimbursed.
Sure. I think that something we talk about frequently in-house and at trade shows is everyone knows that they're being underpaid. It's just a matter of how much, and that tends to sneak up on people. Reed, I don't know if you have anything you'd like to add to some of those questions as well, but I'll turn it over to you if you'd like to take a moment.
Well, I think what we see is we analyze, hospital contracts and payments coming in. We built this state-of-the-art engine where we're taking in the payments every night, and it's not just a periodic thing, but we take in the payments from the claims clearinghouse every night as they've been processed. We load those payer contracts in, and as we model out those contracts, and we have those modeled out contracts in our engine, we're able to look at those payments every day as they come in. And basically, we know that we're able to see that hospitals are getting claims denied that aren't correctly denied. They're getting claims paid that are being underpaid or incorrectly paid. Sometimes they're getting what we call zero payments or missed payments. Basically, it's happening across the board at every hospital we deal with in some way. And so it's just a matter of exactly how it's happening or when it's happening, but we do see it happening across the board. And so it's basically a matter of, we tell hospitals, it's not the old days where you can have somebody come in once a year or once every couple of years to look at these issues, and it's a small issue that you can deal with on a periodic manner. It's really something you need to stay on top of on a daily basis. And I kind of was in a presentation recently, and I told somebody it's kind of like that movie A Few Good Men, where Jack Nicholson's given his epic soliloquy at the end of the movie where he says, you want me on that wall, you need me on that wall. You need us on that wall at SlicedHealth so that we're on the watch for you, watching for these things. And so we're on guard for you, on watch for you, making sure that we're looking out for your best interest.
Absolutely. I really love that. We should put that in some of our marketing somewhere. All right. I think that again, great transition of thought here. In preparing for this webinar, the three of us talked a lot about what does modern day contract management look like? What does data-driven contract management mean? We say that a lot, data-driven contract management. And there's a lot of behind the scenes work going on in a contract, and these may be really long contracts that haven't been updated in a really long time. So Reed, let's continue your line of thought here of what does this modern day contract management look like? What should teams focus on, or what is a focus? What are the benefits to keeping things automated? I'll turn it over to you, but feel free to walk through that line of thought.
Sure. So as I was saying, we built this engine where we've modeled out your payer contracts. We've got all this data in an engine. We're taking in your payments every day, really on a nightly basis. There's no interface required. We get a file drop in the cloud every night from the claims clearinghouse to get that data, the claims data into the engine. And basically, you've got all this data and we're analyzing it. And so, that's not necessarily that different from the way contract management's traditionally been done. What's different is we're bringing it to the community hospital market and offering it to the market in a way that is kind of what I call the easy button, because we do the work for the client in that we implement the product, we maintain the product. The client still participates in the project and validates the data and it's definitely a collaborative process, but we take the bulk of the work off the client's plate. Secondly, as we get the benefits of artificial intelligence and machine learning, we're able to do a faster, easier implementation that happens, in a matter of weeks and a few months, as opposed to what used to drag on forever in the old days. And so it's a faster process. We're able to realize return on investment much more quickly. But at the end of the day, some things are happening in the market with artificial intelligence that we can all take advantage of. We're able to, as Reese was kind of alluding to, we're coming out with some functionality where clients will be able to ask. We're building a chatbot that's coming out pretty soon, where you'll be able to ask it what's in your contracts, and I'll let Reese kind of elaborate on some examples of that. But you'll be able to ask it, different things about what's in your payer contracts, so you don't have to go look through those hundreds of pages of documents about what's in your payer contracts. And the puck is going, we're skating to where the puck is going as to where you'll be able to ask chatbots about the analysis that we're doing. So the days of people having to search through dashboards and things like that, you'll still have those available, but you'll start to interact with chatbots to get the answers you need in a faster, more efficient way. And so that's where the trends are going, and that's where we're taking our clients as well on this journey.
Yeah, so, I think that's really exciting, and I'm glad we get to open that door here and talk about it a little bit. Reese, you're on the product side of things. I'd love your insight into AI. Is an unknown. It's a scary territory for a lot of people, but it opens up a lot of doors. So how do you see vendors like ourselves changing and implementing AI? Where do you see the market going with AI and the benefits that it brings to folks who are currently, going through those contracts manually, or
Yeah.
are reading through all of that, or you're welcome to talk a little bit about what we specifically are doing if you'd like to dive into that as well. I'll open that up to you.
Yeah, I think definitely the biggest thing that AI gives you is a continuous feedback loop of what's going on. It can constantly analyze the data. It can detect things that you wouldn't be able to detect immediately, and then it can even adjust and then help you validate what you're seeing. So when we start looking for trends in this data, like, is there something that is consistently being underpaid or consistently being denied, not just one off, but across the board? If we saw it 6 months ago all the way through the current the current claims and remits that are coming through, that's something that AI can detect very, very rapidly. It can also understand these payment methodologies um, to the nth degree, where it can give feedback to say, this doesn't appear to be correct. And one thing we want to be very careful of is we don't want AI to be making decisions, but we want it to make suggestions and then allow still a human to validate whether or not that's correct. Because there are times where we're not into our contract system, we're not feeding into it lab results and radiology reports and things like that. So sometimes parts of the medical records still have to be reviewed to validate it, but it can ask those questions that you may not think of. And there's normally, you can look at a variance and say, oh, well, I think it's this, but AI can come back and say, well, it could be one of these 3 or 4 different things that you maybe didn't consider to begin with, in order to decide how you appeal that denial or how you appeal that variance. And so that's one of the things we're looking at. Also, the scalability of AI is really, pretty impressive. And again, in that real time trend spotting, the amount of data that you can process through in a very short amount of time is really mind blowing when you start to think about it.
Sure.
Yep.
No, go ahead. Go ahead.
I was done.
Oh, great. I would love to stay on AI for just a second. Like I said, it's becoming more and more known, which is great. A few years ago, it was this big unknown doom and gloom cloud, and nobody really knew what it was, and everyone was. Now people are starting to become more familiar with it. It's starting to be integrated into a lot of tools and processes, and partner vendors like ourselves, or all kinds of different softwares and technologies. I open it up to both of you. As people are maybe evaluating using new tools or implementing the AI of tools as they're evolving, what are some red flags and green flags that people need to be aware of, that they need to either be careful of or will save their team time? What's some of that vocabulary that or some of the demonstrations that you have seen that you think would be good call outs for folks as they're evaluating AI changing this market?
Well, I'll jump in here because I've been looking a lot of what's going on in the market with artificial intelligence, and certainly there's a lot on the clinical side of the market that I've been looking at. Like, there's a lot of artificial intelligence that is being used for diagnosis, particularly around radiology, and certainly, you know, having artificial intelligence, diagnose patients, or there's a lot of this ambient listening and AI assistance to do notes and things like that. And I think if you're getting involved in clinical patient care, obviously that's something you want to proceed with caution with, because there's certainly a lot of liability there, and the FDA can get involved in some of this stuff. On the revenue cycle side, um, everybody's getting involved to try to solve what's a really inefficient system, and between providers and payers and trying to get everybody paid faster and more accurately and more efficiently, right? And so those are the problems we're trying to solve. And there's a lot being done on the front end of the revenue cycle and the middle of the revenue cycle of things. From denial management is a huge focus. And there's a lot being done around things like clinical documentation integrity, which is interesting. And I think I would just encourage people to look at a lot of the different things out there and just try to see if you can do some comparison and not just look at one vendor, but kind of try to see if you can get a grip on what is really real. There's a lot of things that are, I think, being that people are touting out there that aren't real and aren't necessarily completely baked. And there's a lot of companies that are touting things that aren't really real yet. And make sure that people have good security protocols in place, like we're SOC 2 compliant, which I think is really important. And I think, make sure that people have those kind of measures in place. Another thing I would make sure you note about us is, we're trying to fill a certain gap in the market around payer contract management modeling. And so our belief is, and I'll give a little bit of a commercial for SlicedHealth here. We're basically trying to make sure that, when you're submitting claims and you're trying to make sure that things don't get denied, or you're trying to rectify denials or underpayments, that you're informing the revenue cycle with accurate information about what you should get paid according to the payer contract. And so that's what we feel like is a pretty important gap in the market that we're solving for. And, we're really using artificial intelligence to make everybody more efficient around payer contracting. And so that's really kind of the bottom line of what we're doing.
Yep.
Very cool. Reese, you mentioned earlier that AI should help inform and suggest rather than necessarily do, the changes. It should more help assist teams rather than do it all for them. Do you have any other notes, or do you have any examples of maybe hospitals that assumed that AI was doing more than it was, or the opposite, that it's a teamwork, I think is what I'm trying to get at. And so do you have any other examples of where that teamwork, where the human side meets the artificial intelligence side, or whether that's inside of our system or with an actual example of a hospital that you've talked to? I'll turn it over to you.
Yeah, I think there's definitely that validation process that you want to have. And that was actually one of the things I was going to discuss for red flags, is you can't have over reliance on AI, because there's all kinds of reasons why it's not the end all solution to this, especially when, and I'm going to say that, some people probably think, well, I can just go to ChatGPT and upload my contract and it'll read it and tell me stuff about it. And then, or I could go out to ChatGPT and ask it, hey, this is my denial. These are my charges. These are my denials. What do I do? But when you do that, you're not doing it within an ecosystem that has all of the prompt engineering built to give you what you need for that complete feedback loop, and including things like contract awareness. If you're just going to ChatGPT, it knows nothing about your contracts. It's just going to give you a one-time analysis of that one claim based on the information that you gave it, and it's going to forget about it. You're also going to get very generic answers. There's no trained models. And so when we're doing this, we're building our prompts to say, hey, here's the contract information. Here's the detail behind what happened from the remittance and the claim file. Here's what we've already determined as far as how the contract should have been paid. And we're just using AI to validate all of that information for us, and realize we're also doing that behind a HIPAA compliant, a BAA compliant, environment that we've got completely secure, and we're not allowing that to go out and train other public models and things like that. I definitely wanted to mention that, but definitely, as Reed said, we want to use the entire platform to inform the revenue cycle. And so we're making sure that all of the key pieces are in place. Your contracts are there. We have the claims data. We have the remits data. We have the fee schedules. We have all the pieces to the puzzle that we need in order to then inform your team, or inform an RCM team if you outsource it, or inform, our partners that we do RCM with. We're going to inform them of all of that data, and really what we're trying to do is give them a single place to view that, to where they don't have to go over here and look. They don't have to go over here. It's all right there in one system that gives them the needed information to make the best decision on how to appeal that denial, how to process that variance. And then also, hey, here's 100 other times the exact same thing happened. You're either being mispaid every time, or what's the root cause of this? Maybe you're using too many unspecified diagnosis codes, or maybe you always use the wrong modifier, or maybe your doctor is not being descriptive enough in his notes. Therefore, whatever you're using if you're using computer assisted coding, it's not finding the information needed in order to give you that higher level of specificity in the diagnosis code. So it's just, again, informing the entire revenue cycle of the hospital.
Thank you. That was a great answer. Reed, before we move on, any other thoughts you want to add onto that? I know this was a very big topic, so I want to make sure we close the loop on that before we move any further.
No, I think we're good.
Cool. Great.
Thank you.
No notes. That's always my favorite. So as we kind of get towards the end here, first off, to those watching, that chat is still open, and any questions that you have, I'm happy to make time to make sure we answer. So feel free to ask away. But as we close out today, we have a wide variety of folks watching today, and some are clients, some are not, some are considering contract management solutions, some are not, some keep it all in-house and are still, flipping through their contracts and reading through all of that. So what I want to make sure that we leave people with today is, what should teams be focusing on moving forward? What are strategies that people can take home today that help them catch missed revenue before it disappears? So we can keep it, at a high level, and then dive into our solutions if you'd like, or vice versa. So Reese, why don't we start with you? I'll restate what are the strategies people can take home today that help them catch missed revenue before it disappears?
Yep, absolutely. And some of this is probably going to be obvious, but it amazes us every time we speak to some clients or even prospects that they don't all have these processes in place. But I would say some of the key things are you want to obviously focus on your highest volume of claims, whether that's a Blue Cross or another commercial claim, or Medicare Advantage payers. You're going to find the most, probably the most issues in your biggest payers. So start there. And that's how we implement our system too. We're going to start with your biggest payer and then move to the second biggest payer and then the third biggest payer. So hopefully by the time we're 5 or 6 contracts in, we're dealing with 80% of your volume. Another thing that we see is a lot of people, when they register patients and when they load insurance plans against patients, they do not separate out Medicare Advantage versus commercial plans. They load Blue Cross as Blue Cross regardless of the plan. They load, Aetna regardless of the plan. But you're really doing yourself a disservice when you're not specifically loading it as Blue Cross Medicare Advantage or Aetna Medicare Advantage, because it's very difficult then to determine which one should have been paid how. Now you can take the payer's response as as the truth. But if I always say, do you want consistency or do you want accuracy? Are you going to accept what the payer does every single time as being accurate? I would say no. They may be consistent, but they're not necessarily accurate. And that's what we're going after. We're going after that accuracy. And then also, when we build our system out, we have a lot of dashboards and ways that we look at the analysis. And so the next step would be, make sure that you have the ability to see a dashboard or an analysis with those variances. Do a regular review of your contracts. Don't let it go 3, 4, 5 years before you start to renegotiate your contracts. Those people think of it as insurance. People look at their car insurance, their house. As soon as that insurance premium goes up just a little bit, they're looking around to say, hey, who can I use to get this lower? Well, think about the same way with your insurance payers. How can we get better reimbursement out of these payers? So review those contracts regularly. And then communication between internal teams. We see that a lot where they don't have clear communication between the billers and the registration team and the medical records team, but having that clear communication to identify those root causes is also something that will help. All of that outside of a contract management system.
Thank you. Wow, I love all of that. Great information. Reed, what would you like to add to that, or what do you think that people should look for in a contract management system, regardless of the ones they're evaluating?
Wow, no, hard to add to Reese's eloquent response there. But I would say, for me, I always look for, something that's going to be easy to implement, easy to use, just an ease of use experience. And that's what we try to shoot for at SlicedHealth, but I mean, whether it's SlicedHealth or another system, any system, even beyond contract management, is try to find something that's not difficult to use, something that's going to be as easy as possible in implementation, something that a company that's going to give you great support when you have problems with it, because software's not perfect, so you're going to have issues no matter what software you buy. You're going to need support at some point. So something that can be easily implemented, easily supported, something that's got a good user experience. The screens are easy to navigate, to get the information out of it that you need. And typically modern software that's hosted in the cloud, that's going to be secure. And so that kind of experience, on top of all the functionality and things Reese was talking about, these days, I think all those things are important. Cybersecurity is important these days, and look for companies that are hosted in the cloud, that are SOC 2 compliant, and give you a great user experience so that you can operate the system as well.
Thank you. I think as we as we kind of close up shop here, I think one of the concerns that we hear across the board from a lot of teams are that teams are stretched thin, or they have maybe a lack of staff, or a smaller staff, and feel like some of their revenue gaps are unable to be closed because they just don't have the manpower. So I think as we kind of look through these slides and look through what we've talked about today, one of those gaps is not necessarily in the contracts, but something that teams are having a difficulty solving in staff time, staff hours, or just warm bodies to be able to help with this. So I know it's a big question, and we'll wrap up here shortly, but what would you all recommend to teams that are dealing with that question in particular of, I really need help closing these gaps. I really need help finding and identifying these underpayments and going after the reimbursements, but I just don't have the staff or I don't have the time. What do you think you would recommend to those teams being able to leave here and get started on something?
Yeah, I'll take that, I guess. I think one of the thing, and we've kind of already discussed it, is being able having a system that really is able to identify those trends and anomalies in your payments data and in those variances. We have a dashboard that kind of says, all right, so everybody's stretched thin. Everybody wears multiple hats in your organization. If you could only work 5 or 10 claims a week, which ones would that be? And so we try to identify the kind of the biggest bang for your buck claims where you're not going to be able to go through 100 claims a week, but maybe you can find time to work 5 or 10. And if those are the ones with the biggest variance or the highest likelihood of being overturned, then we'll present those to you. And some of that will get better as AI we continue to develop our AI processes within that as well. So I think that's one thing. I think also, when you go to implement a contract management system within your team, be realistic as far as what you're going to be able to handle. Because if we analyze your claims and we come back and say, all right, well, here's 10,000 claims that we found out of the last 12 months that could possibly be underpaid, you're going to be overwhelmed and your team is going to immediately shut down on you and be like, we're not even going to use this platform. There's no, so we have try to avoid that, be realistic, set goals and say, well, let's just see if we can work 50 claims a month and try to get those. So, that's one way that you can deal with being stretched thin. Another way is to ask for help. So you can always find an outside agency or an RCM team that will possibly be willing to help. That may cost a little money. You may give up a little bit of that of that of that of your reimbursement, but realize if you're not going after underpayments right now, it should all be found money anyway.
That's right.
So, yep.
Reed, do you have anything you'd like to add on that?
No, that's pretty good advice from Reese. I think you covered that question pretty thoroughly.
Sure. Is there anything else as people leave this today? We get a lot of questions and concerns about, I don't have the budget for something like this. I don't have the staff time like we just talked about, or it's a longer decision process. Do you feel like you've heard any trends in when people realize that they need some help or start to tackle how do we reprogram our team to be able to tackle some of these issues? Have you noticed that there are any trends in how people then approach making those changes or going to their board or restructuring their teams? Are there roles that become highly important in those teams that become executors on these teams? That's a big question to wrap up, so it may be one for another time, but I don't know if you have a brief answer for that or not.
Well, I would say, the way we're structured as a company, we're built for the community hospital market. So this is often not a big budgetary decision. We're built as an operational cost, built to be affordable and built to be something that can be implemented quickly and easily. And so, that's kind of the way our company's built. And so, I wouldn't make assumptions about this being a large capital cost and, that kind of thing. So
Sure.
that's typically the way we do it. So I would invite people to, certainly explore their options and take a look at, what's out there and certainly get to know us and understand, what we have to offer. But, that's the difference between, the community health system market and the traditional larger IDN market as well.
Sure. Thank you. I know that was a big question. You did a great job of answering it in 2 minutes. So I appreciate it. We do not have any questions in the chat. So one last, turn over to you two, are there any closing thoughts that you'd like to leave people with, or anything
I
that?
do see a question in the chat.
Oh, do you?
Yeah.
Oh, it's not popping up on mine. Do you?
Yeah, it
Oh, it's
says, how are
Q&A.
your
Oh,
fees
here it is.
based?
It's in the Q&A. My bad. How are fees based? Yeah, great question. Thank you so much. I'll turn that over to you two. We'll get that discussed.
So basically, the way our fees are based, we don't charge any implementation fees, so we make it easy to get started, and then we charge a low monthly subscription fee. And so we offer different products, from contract management to price transparency to claim estimation, to business intelligence, and basically, and we're including our new artificial intelligence products as well. So you just pay depending on which products you want, and we offer different bundles depending on, the combination of products you want, and you just pay a monthly subscription fee based on the products you want. And subscription fees start on day 30 after contract signing, so it's really simple. And the way Reese was talking about, we implement is we start with your largest payer contract first, and we get to working on that, and then the goal is to deliver return on investment as fast as possible.
Yep. Definitely try to avoid the capitalization and big upfront implementation fees. So we just do a flat subscription fee.
Yeah.
I'm glad you saw that question. I had too many screens up at once, so running too many shows here. Are there any other questions? I'll give it, just a minute. We're wrapping up just on time here. So, while we do some closing housekeeping, if you all have any other questions, feel free to drop them in the chat or the Q&A section. But this will be available to you all via our website. You will see an email come in from me and my team. It will come either from my name or marketing team at SlicedHealth.com. You are always welcome to reach back out to either of those email addresses and ask any other questions, or set up some time to talk with any of us if you want to involve more of your team and ask more specific questions. We will make sure that you have a recording of this available to you as well. And really, we ultimately just thank you for your time. Our goal is to make sure that you spend the most time possible taking care of your staff, and they can take care of your patients, and make sure you're plugged into your communities. So the more that we can take off of your plate and close some of these revenue gaps and give you some of that hard-earned payment back is what we want to be doing. So I appreciate you all being in the call with us today. And if there are no other questions, I will give everyone the gift of time, and we'll wrap up a little bit early. So Reed and Reese, thank you so much. And I appreciate your well thought answers, and look forward to hopefully doing another one of these with you.
Thank you, Eden.
Thank you.
Take care.
Thank you all.
Everybody have a good holiday weekend.
Bye.
You too.